look at, and both on the part of physicians and patients, there tends to be undertreatment, which is unfortunate because it's by far one of the more treatable conditions that we deal with medically. And if not treated, it can have serious consequences. If treated, the outcome can be very good. All right, I'll continue to the next part, I guess, and then at the end, maybe we'll take questions about both topics. So,
what am I looking for?
same thing.
The same?
Blood pressure, the first set of slides. Is that it?
Right,
No, you won't.
no.
Oh, no. That's it. That's the one. No. Oh, yes. Okay.
That's it?
Sorry. I guess that wasn't the last slide. I don't know why we had that blank. So I'll just.
Oh, that was the problem. That's what it was. It was a blank slide, and that threw me off.
Okay. Go back once. I'll make sure I'm in there. Yeah. Okay. That's fine.
That's the problem.
I just bring this.
Is that what it's supposed to be?
That's fine. We're okay. Sorry for the interruption, then. We're still on blood pressure. There is these days something that can be very helpful for many patients. There are patients who come into the office and who say, but when I go into the drugstore or at work, my blood pressure is always normal, but it's very high when I come into your office. And that is a serious problem that we have to deal with, because while we need to treat blood pressure, we don't want to over-treat blood pressure. And there is something that's called white coat hypertension. It's not all that frequent, but some patients, when they come into a doctor's office, the pressure goes up, but tends to be normal the rest of the time. That's fine if it's true, but you don't want to overlook and not treat if that's a mistaken impression. So we do have these days what's called automated blood pressure monitoring, or patients can take their own blood pressure at home with appropriate devices that should be checked by the physician. The benefit of home blood pressure monitoring is that it will uncover unusual types of high blood pressure, such as white coat hypertension or pseudo-hypertension. It will also help in the timing of therapy. Is it best to take the pills in the morning, at night, how to split them up? It will permit dosage adjustment, and it will avoid what's called orthostasis, which means some patients will have a reaction to the blood pressure medication, and the blood pressure may drop when they stand up. And by doing measurements at home in the right settings, occasionally in the office, one can pick this up and adjust the medication accordingly. So, I said this to you before. Hypertension is a common cause of multiple problems, including mortality. It causes cardiac, brain, and kidney damage. It's silent, but there is safe therapy available. And right now the problem is that patients often don't adhere, and even physicians often don't recognize the need to be aggressive in the treatment of this condition. Excuse me. Sorry. Okay, I told you before why I'm giving a talk on both high blood pressure.
When do you normally give pills, really? When the pressure is about what? 140, 150?
Say that again, please.
When do you treat the person with blood pressure? If the blood pressure is around 140, 150, 130?
That's a good question. And the answer is that there's some debate in the medical field at the moment as to which levels and to what levels the blood pressure should be treated. But in general, any blood pressure over above 140 or 150 for the upper number and over 90 for the lower number is clearly recognized by most people as hypertension that should be treated. Excuse me, to exactly what level it should be treated, there's some debate, but roughly speaking, somewhere in the range of 120 to 130 over 80 is where you'd like to get the blood pressure down to. Okay? Now, as I told you before, one of the major organs that's damaged by high blood pressure is the kidney. The kidney can also be the cause and a frequent cause of hypertension, and some people would believe that it's the major cause of essential hypertension by mechanisms that we don't fully understand. So, here are the kidneys in the body. They're in the back, what we call retroperitoneal. You see the two kidneys and the what's called ureters, or the drainage tubes leading to the bladder. The slide on your right is the same slide, except it also shows the blood vessels leading to and from the kidney. But essentially the kidneys are in the back, in the abdominal area, and this is a sort of schematic appearance of the kidneys. There are two broad categories of kidney disease. Symptomatic, where patients do have symptoms, such as patients who have kidney stones, or blood in the urine, or infections with burning on urination or the like. Most of the conditions which produce symptoms, again, this is a simplification, but most of the conditions that produce symptoms in the kidneys or from the kidneys are non-progressive. They're not going to cause progressive damage and loss of kidney function. Now again, that's a bit of a simplification, but as a broad statement, it's true. Progressive kidney failure, whether it's acute or chronic, is often, like high blood pressure, silent, and patients may not be aware that they have this condition until the condition is very advanced and causes a variety of complications. But the kidney disease itself may be silent. What are the clues? What should make one worry, either the individual or the physician, that kidney damage may be present? Well, high blood pressure, because the kidneys or kidney damage causes high blood pressure. And the other very important parameter is proteinuria, or protein in the urine. In fact, there's a general, universal, but certainly national recommendation now that patients, particularly patients with certain conditions such as diabetes, who may be prone to kidney disease, be screened on a regular basis for protein appearance in the urine. The appearance of protein in the urine is often an early sign that kidney damage is present and needs to be addressed. Blood may be present in the urine, and the other most reliable method of detecting kidney disease, not necessarily the earliest. Proteinuria may be the earliest way of detecting it, but the other way is by measuring the blood, by doing blood tests, particularly measuring a substance in the blood called the serum creatinine, which for the moment is our most sensitive marker of the presence of kidney disease. It goes up when kidney disease is present, and we can recognize it that way. A decreased urine output is generally something that occurs in very acute kidney disease. It is not usually present in progressive chronic kidney disease. Patients may have a normal urine output, but it's a poor quality urine. So again, the parameters or the measures for screening for kidney disease are high blood pressure, protein in the urine, and a blood test measuring particularly the creatinine. The causes of kidney disease are multiple, and again, we are not going to go into them in detail, but they can be hereditary, and some of the hereditary conditions may be very slowly progressive and may not make their appearance until the patient is in the 40s or 50s, so, or even older. Some may manifest in childhood.
How about Jewish people? Are they more prone to it?
Not specifically, no. Things in the environment, particularly toxic or poisonous substances. People who work with lead, for example, just as one example, can have kidney damage, but there are many other toxins. There are a variety of drugs, some which may have to be given for serious conditions, but carry the potential risk of damaging the kidney, and there are a whole slew of drugs, antibiotics, chemotherapeutic agents used for cancer and the like. A blockage of the kidneys can cause kidney failure, blockage of the blood vessels to the kidney, that's vascular, can cause kidney failure. Certain tumors can cause kidney failure, and their hormonal causes, the most important one being diabetes. Diabetes accounts for 50% of all the patients who are on dialysis in the world. So diabetes is the single most important cause of progressive kidney disease. And diabetic patients, of course, need to be particularly monitored for kidney damage. The other big group, of course, is patients with high blood pressure from other causes. There are certain infections that can cause kidney disease, hepatitis, HIV, and so on. And there are a number of what we call immunologic conditions. Some of you may have heard of something called systemic lupus, erythematosus, periarteritis, scleroderma. These are inflammatory immunologic conditions where something happens in the body and the body starts producing antibodies which normally are directed at foreign substances, bacteria or tumor tissue, but in this situation the body produces antibodies that damage its own tissues, and that can cause immunologic progressive disease. In order to understand kidney disease, we need to understand a little bit about what the normal kidney does, and we'll talk about that briefly. The functions of the normal kidney are, first of all, to eliminate waste products, and these waste products may be products that are produced in the body during normal functioning of various tissues, muscles, and so on. They can be substances that we ingest. For example, if we take in certain drugs or other substances, the body has to get rid of them. And the two main organs for doing that, one is the liver and the other one is the kidney. Those are the two most important organs for eliminating substances from the body. And of course, we eat a lot more salt than we need. We eat potassium, we may drink more than we need. The kidneys eliminate those products. So the function of one of the main functions of the kidney, the first one that we understood because it's sort of self-obvious, was its eliminating function of these various components. The excretory or eliminating role of the kidney is one that we mentioned. The other function that the kidney does is it controls the blood pressure. It controls the blood pressure in a variety of ways. One is because it controls the amount of salt and water that the body retains, and the other one is because the kidney produces or metabolizes certain hormones that may be involved in the blood pressure. Volume control and salt I mentioned. It produces various hormones. The kidney also does something else which we did not know or appreciate as well in the early days of studying the kidney, but once patients were able to survive on dialysis and live longer on dialysis, which replaces the eliminating function of the kidney, we found out that there was something else missing, and that was the metabolic or hormonal function of the kidney. And it turns out that the kidney is very active metabolically. It degrades substances besides eliminating them. It breaks down certain types of hormones and other proteins. It produces certain hormones which are very important in the body. Erythropoietin is a hormone that regulates our red blood cell or our hemoglobin levels, and that's damaged in kidney disease. The active form of vitamin D, which regulates our bones and our calcium levels, is produced in the kidney. So it's a very important. The kidney is much more than just an organ that eliminates substances from the body. Now, those are the normal functions. The consequences of damage to the kidney, therefore, flow from that. When kidney function is impaired, the kidney is less able to, sorry for the misspelling, is less able to eliminate salt and water from the body, which can lead to a swelling of the body, fluid accumulating in the lungs, or worsening hypertension. The body is unable to eliminate certain poisons that are produced by normal daily metabolism of various tissues, and the kidney may not be able to get rid of various drugs that we ingest, which have to be very carefully adjusted when kidney disease is present. Hypertension is generally worsening kidney disease, and because of the metabolic function is impaired, kidney patients, for example, will often be severely anemic and will develop bone problems. In the early stages, some of the problems may be difficult to distinguish from just normal aging. Kidney disease is much more prevalent in the older population, and when an older patient comes in fatigued, with maybe not a great appetite, less energy than usual, it may be difficult to distinguish that from just the fact that they're now older versus they're having kidney disease. They may also have some other medical conditions, and it becomes very difficult to distinguish some of these subtle manifestations of kidney disease from other conditions that may be causing this. These problems, however, get more severe and more common as kidney disease worsens, and over time, kidney damage will involve just about every organ in the body. I mentioned fatigue, etc. As you can see, decreased sexual interest, sleeplessness, and so on, anemia, and a variety of other problems. And very important, as you can see, fractures can occur, and calcium can deposit in the tissues, causing damage, in the blood vessels of the body, causing progressive damage and decreased blood flow to organs and the heart and so on. So kidney damage over time can involve all components of the body and cause some serious consequences. Kidney disease causes problems in the gastrointestinal tract with nausea, vomiting, and GI bleeding. So we often have to call on gastroenterologists to work with us. As Dr. Bright knows, patients with kidney disease in particular have heart problems. They're unable to eliminate salt and water, therefore congestive failure may be a common problem in patients with kidney disease, and they have an increased incidence of atherosclerosis. They may also have neurologic problems. In very advanced kidney disease, patients' ability to concentrate, to focus, to think clearly will be damaged. And if the kidney disease is more advanced, they may develop neuropathy, damage to the nerves of the legs and the hands with tingling, decreased sensation, numbness, or they may actually have seizures and coma. Blood sugar control gets worse, bone disease develops, skin abnormalities, and so on. Now, how do we treat or how do we deal with kidney disease to try to avoid all these complications? Well, one thing is that we need to recognize it because it can be silent, and therefore patients should appropriately be screened depending on their age and their underlying associated medical conditions. Patients with high blood pressure, and particularly patients with diabetes, need to be screened routinely for presence of kidney disease. Patients with a family history or previous kidney injury need to be screened by these mechanisms. Depending on the cause, we may be able to arrest or prevent the progression of the kidney disease. If there's blockage of the kidney, that's one of the, with stones, tumors, scarring, that's one of the more treatable ways, conditions that can cause kidney damage. Occasionally, if the blood vessels are blocked, that can be dealt with. High blood pressure, if treated, is a very important way of slowing or preventing kidney damage, controlling the infections that may be present, such as HIV or hepatitis. And for immunologic conditions, we use agents similar to the ones we use in the treatment of cancer to try and prevent the inflammation and the inflammatory process from progressively damaging the kidneys. In patients with diabetes or patients who have protein in the urine, but particularly diabetes, the two classes of drugs or the two categories of drugs that I mentioned before, the angiotensin converting enzymes inhibitors and ARBs, are very important, and they should be part of the blood pressure treatment in these patients. And even if the blood pressure is normal in these diabetic patients or proteinuria patients, these drugs may often slow progression of the kidney disease. Very good blood sugar control in diabetes is very important. And there's an ongoing search, and we're constantly evaluating new drugs so far without success in trying to find a drug that will prevent the progression of diabetic kidney damage because it's such a common problem. It's both a clinical and a socioeconomic problem because of the scale. Like I said, 50% of chronic kidney disease is due to diabetes. Now, did I skip something? No. If the condition doesn't respond to therapy or is too advanced by the time we diagnose it, which unfortunately is not uncommon, then what we have to do is monitor for complications. We can't prevent the progression. We may or may not be able to slow it down, but we can't prevent it. So then we have to follow the patient, number one, to prevent the complications and treat them, such as the anemia and the bone disease that I mentioned, and also at the appropriate time to educate the patient about the different forms of dialysis or kidney transplantation that are available, so that when the time comes, the patient is not making emergent, last-minute decisions when it's often much more difficult. The patient is sick, everyone is worried, it's much more difficult to think clearly. So it's very important for patients who have advancing progressive kidney disease to educate them at an appropriate time so they can make decisions about a variety of issues, including the type of dialysis or transplantation and the like. It's important to institute therapy to slow or prevent the complications, blood pressure control. You want to prevent the accumulation of salt and water and congestive heart failure or swelling of the legs. These patients are often malnourished because they lose their appetite, they may have nausea, vomiting, and malnutrition is one of the main causes of mortality and morbidity in chronic kidney patients. So that's very important to address. They have an increased tendency for high cholesterol and the complications thereof, so that needs to be treated. They can be, as I mentioned to you, anemic, and we have various ways of approaching that, and we want to prevent the bone disease that can occur and the hormonal problems that can occur. And as I mentioned, we want to prepare them and educate them in a timely way for dialysis if that becomes inevitable. If we can avoid it, so much the better. But in many patients, that's unavoidable, and then it becomes important not to delay the start of dialysis, because if patients start too late, they often end up having dialysis by less than desirable means, by using what we call a catheter, which is a tube put into a blood vessel through the skin. The problem with those is they're associated with very high incidence of very severe life-threatening infections. The dialysis is not as good as it is otherwise. What we like to do, you may have heard the term, is place a fistula in the arm for better, safer dialysis, but that takes time to perform and to mature. Patients who are referred late to a nephrologist often have increased mortality, prolonged hospital stays, things that are avoidable if the disease or the condition is diagnosed in a timely fashion and addressed appropriately. We then need to educate the patients about the different forms of dialysis and transplantation that are available, place the fistula, and start dialysis at the appropriate time and have them evaluated for transplantation. Renal replacement therapy is a generic term that includes dialysis and transplantation. There's several forms of dialysis. There's what's called center hemodialysis. There's home peritoneal dialysis, which is a treatment that's done by the patient through the abdomen, very safe, very gentle, very effective treatment. There's now coming into vogue as a new approach. We have to find out if it's truly better, but what's called daily short dialysis. Normally, center dialysis is done for 4 hours, 3 times a week, whereas daily short dialysis is done at home, which is always a better environment for the patient, a safer environment for the patient. The patient has to learn how to do this, but they do treat themselves daily. Our own kidneys work 24/7, which is much better than 3 times a week. but we do send to dialysis 3 times a week because we have to permit patients to have a life outside of their dialysis and not be in the center 6 or 7 days a week, and it's very costly, but home dialysis patients can perform on their own. It's in a shorter time, and that's coming into vogue. There are some patients, although a small group, who perform maybe the best dialysis available is they dialyze 5 to 6 times a week at night for 8 to 10 hours, which may be the best treatment. But again, not many people are able or willing to do it. And the best treatment for kidney failure, the best renal replacement therapy, is transplantation, because a new kidney replaces not only the waste removal functions of the kidney, but replaces all the hormonal and blood pressure controlling effects of the kidney. So when available, that's the best type of treatment for kidney failure. And there are several types of transplantation. There's an unrelated deceased donor, there are related living donors, and then there may be unrelated altruistic living donors and variants thereof. This is the best therapy for kidney failure. The trade-off is, of course, that the patient has to undergo a surgical procedure and has to take drugs to prevent rejection of the kidney, and they can have side effects. We've gotten better, the drugs are more effective, they have fewer side effects, but the side effects are there and potentially something to be considered. The limitations on transplantation are, most importantly, there are not enough organs available for all the people who need them. In the United States, we do about 10,000 transplants a year. The waiting list is about 90,000. So it's a very major problem. Not enough people are willing to donate organs. By the way, in Israel, the problem is even worse because the Haredi community doesn't or hasn't wanted to in the past to participate in organ donation. And at one time, Israel was excluded from receiving organs from Europe. Really problematic. But in general, around the world and in the United States, there are not enough organs available for all the people who need them. Maybe one day we'll be able to figure out how to get organs from compatible animals, but we're a ways away from that. By the way, I mentioned this because of a discussion I had recently. At the moment, the most promising animal is a pig for that, because it's closest, call it genetically, if you will, it's not the right term, to human beings, but we're not there yet. And in New York, for example, the waiting times are up to 5 or more years for someone to get an unrelated organ. If they have a donor, obviously they get it sooner, but it's a very problematic issue. So in summary, kidney disease is often silent, and in early stages it doesn't have symptoms. It has a number of potentially treatable conditions, but in many other cases it tends to be progressive, and recognition is still important to prevent associated complications, to initiate timely renal replacement therapy. Hopefully in the future we'll be able to do better organ transplantation, have some source of better organs, maybe figure out how to prevent certain types of kidney disease, such as diabetes and the like. Thank you.
Are you in favor of people paying for kidneys?
Excuse me?
Are you in favor of people paying for kidneys?
That's the question that was raised was, am I in favor of paying for kidneys? That's a very, very, very complex topic and very difficult because it obviously is open to abuse and so on. I would tell you that if I have major reservations, but if I were